Chionieri, we see the plantar plate depicted in red, and the deep transverse intermetatarsal ligament, another static stabilizer, will blend with each of the plantar plates. Each of the MTP joints has paired accessory collateral ligaments which insert onto the sides of the plantar plate, and phalangeocollateral ligaments which extend from the metatarsal origin to insert along with the plantar plate onto the base of the proximal phalanx. And the extensor hood inserts onto the collateral ligament complexes. There are dynamic stabilizing tendons, including the flexor and extensor tendon, the dorsal and plantar interosseous tendons, and the lumbrical tendon. Remember that you need an intact plantar plate to provide lesser MTP joint function and stability. And that's why the vertical stress test is the best clinical test for plantar plate tear. You stabilize the metatarsal head while you exert a vertical stress on the toe, palpating over the MTP joint to feel if the base of the proximal phalanx subluxes or dislocates. If there's instability, this typically reproduces the patient's pain. The caveat being that lowest grade tears are stable on examination. So here we have the current examination, and this is a normal comparison. And I'm going to review the imaging appearance of the tear and the normal plantar plate. And at the medial insertion, we see that the plantar plate is intact in the index case and normal comparison. As we progress centrally, we see there's a smooth thinning of the plantar plate, but we don't see a focal defect. Notice by comparison how robust the plantar plate appears in the normal case. And as we get to the midline, we see a through and through fluid signal defect in the plantar plate. In this high-grade plantar plate tear, undoubtedly associated with MTP joint instability. And out at the lateral insertion, we see an insertional tear with contiguous insertional tearing of the lateral capsular structures. There is an anatomical grading schema. Grade 1 is a small tear at more commonly the lateral, but it can be the medial insertion of the plantar plate. Grade 2 will cross midline. Grade 3 will be even larger with longitudinal extension either centrally or at the periphery, as in our case. And grade 4 tear is a buttonhole type tear in which the metatarsal head can protrude through the defect. So with this plantar plate tear, there are acquired toe deformities. Most commonly, you'll see a tibial drift of the affected toe, which is most commonly the second toe. And there's often associated hyperextension of the toe, which goes along with loss of digital purchase, which is loss of the ability to dynamically press the toe against the ground. End stage cases is described as a crossover toe deformity, in this case affecting the second and third toes. You should note that deformity and dysfunction worsen as pain diminishes. A pseudoneuroma is reactive pericapsular soft tissue thickening, which forms eccentrically along the plantar plate and capsule, depending how acute or chronic it can be. A mixture of inflammation and granulation tissue or scarring. This is seen in the vast majority of plantar plate tear, and not surprisingly contributes to neuritic symptoms quite similar to Morton neuroma. In this case, we can see that eccentric pericapsular soft tissue thickening. Contrast this to a typical Morton neuroma, which most commonly occurs in the third web space and is centrically located in the plantar aspect of the third web space. On behalf of the RSNA and our speakers, this concludes our session on case-based review of musculoskeletal imaging. We thank you for your participation and look forward to your feedback.